Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Felicia Francois receives an honorarium from Speech Therapy PD for podcast participation and has no relevant non-financial relationships to disclose. Renee Garrett is the owner and founder of BrainBridge Connect. She hosts Brainstorms, functional neuro rehab for SLPs, and receives financial compensation from Speech Therapy PD for the podcast and other educational webinars. She's also an adjunct instructor at both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Felicia Francois, MS, CCC, SLP. She is a queer, non-binary, white speech-language pathologist specializing in voice and upper airway. They have a passion for gender-affirming voice care and lead the Gender-Affirming Voice Care initiative at the USC Voice Center in Los Angeles, California, where they also work with performing vocalists and a variety of other patients with voice and upper airway disorders. She is passionate about advancing research for gender-affirming voice care and improving the quality of life for those with voice issues. Felicia, thank you so much for being here.
Thank you so much for having me. It's a
Of
pleasure.
course. So I know we have a few questions, but one of the things that always interests me about people who specialize in this in sort of a niche area, because this is a different area. Not everybody is certainly competent or qualified to deal with voice and upper airway in the way that you do. So is there a background story? Do you have a performance background? Are you a singer?
Yeah, I'm definitely a member of the singer to voice SLP pipeline. I went to school, undergraduate degrees. I did a double major, bachelor's in vocal performance and a bachelor's in choral music education. And then I was a middle school choir teacher in Greensboro, North Carolina, and a private singing teacher for a few years before I stumbled across speech pathology, actually. So that background is definitely there.
Middle school, bless you.
Yes, I still have the nightmares to prove it.
I just think it really takes a special person. That's such a volatile age group with hormones and all the things, and
Yeah, I
definitely
did.
different.
It is, and I have so much respect for my colleagues back in my old county who are sticking with it or across the country with that age group. There is a reason why I am now treating adults.
I
Wasn't
feel
wasn't there.
that.
Yes, yes.
Yeah. So let's kind of jump right in. What is your philosophy for affirming voice care? Maybe we should even back up a little bit and just talk about what gender affirming voice care is.
Yeah,
Because I think a lot of people aren't familiar, maybe just really don't know the gist of it.
totally. Yeah, gosh, I think it's so broad and it can look so different, which sort of informs my philosophy. So I feel like the questions actually go together. It can look like so many things. And I think, right now we're hearing a lot about gender affirming care. I think when we think about it, most often it is for trans or non-binary or gender non-conforming or gender expansive folks. But I will say that cisgender patients also get gender affirming care. When I have a woman who has smoked 2 packs a day for years and she has Ranke's edema and her pitch is too
Yeah.
low, and we are working on non-surgical ways to make her pitch higher, that's gender affirming, or a cis man who wants to sound more authoritative in the boardroom, things like that. So it can look so different depending on who you're working with. But specifically, my focus leading the Gender Affirming Voice Care initiative is gender affirming voice care for gender expansive people, trans folks, non-binary folks. And it's really working on ways of producing voice to create and create a voice that aligns with how they want to represent themselves and how they want to hear themselves. I think, and that can, again, look so varied depending on the person. Creating a voice that is affirming, feels good, and brings about a sense of euphoria. I think those of us that maybe have heard these, big terms of gender affirming care have probably heard of gender dysphoria. And I think that we sometimes approach this care thinking about alleviating gender dysphoria, but I actually think about it in a different way. I think that a lot of what we do as SLPs is bring joy into communication, no matter what population we're working with. And I think that informs my approach to gender affirming care and gender affirming voice is bringing about a sense of euphoria in the voice where maybe there isn't a lot of that currently.
Well, and I think it might be important because I don't know, the background of all of our listeners to define what cisgender is. I know that I know, but a lot of people don't. So can you kind of
Yeah.
explain what that means?
Totally. Yeah. Might be a common term nowadays in my realm for sure. Cis just is the Latin root for same. So your cisgender is the majority of people are cisgender. Your gender is the same as what was presumed at birth. And so then breaking apart the word transgender, your gender is different or differing from what was assigned to you at birth.
Okay. Thank
Yeah.
you. Thank you.
Yeah.
Because I think that's helpful for people who maybe haven't had experience in this realm and certainly not, maybe familiar with different terminology. So I just wanted to
Totally.
clarify that. So thank you.
Yeah, of course.
Yeah, and I really think that, the performance background piece, the teaching piece, I think all of those things, because when you come into this career as a second career, as I also did, it
Mhm.
gives you a different perspective on kind of what you were leading up to with patient-centered care and
Mhm.
shared decision making as far as goals. And I'm not sure that I know again what Rinke's edema is because I've had patients that I had to refer to someone else because that wasn't my specialty area. But is that an just a quick brief overview of what that looks like? Because you mentioned smoking and it has an
Oh,
impact on on vocal folds, and I would just want to make sure that people understand what you're talking about.
totally. And this is how, we go in our little silos and we get so like in the trenches of our things, our little subfields. So that is something that often happens mostly to women, which is unfair, who smoke, which is a swelling of the Ranke's layer of the vocal folds, which is just one of the many layers of the vocal fold tissue that causes the vocal cords to be thicker and have vibrate slower. So it sounds like kind of what we think of that smoker's voice, that low pitch.
Mhm.
Hmm.
Yeah, I did a really cool course on that just on my own years ago from the University of Wisconsin Voice and Swallow Clinic, and so again I knew what it was. I knew I was familiar, and they have really good clips of what it sounds like, but kind of tying into that, one of the things that I talk about with my undergrad students in particular is just different technology and apps, and showed them the app called Voice Tools, and it
Hmm.
rates your voice as male or female and then androgynous. And so a lot of even the undergraduate students weren't familiar with what androgynous means, and they were like, oh my gosh, so I'm not a guy or a girl. And I'm like, that's not exactly what that
Got to
means.
dive deeper into some of those. Yeah.
Yeah. So if hopefully if I ask you that, it's more of I want to clarify for the audience so everybody understands that terminology. Maybe if they aren't in the voice world, if they haven't been familiar with treating or, seeking out CEUs that kind of cover that kind of stuff. So thank you for being flexible with that.
Yeah, of course. And maybe we'll get into when we talk about treatment, but I use that Voice Tools app still to this day and still have not paid for the paid version. I was watching ads in the middle of a session today. So I should
Hey,
probably drop
well,
that $5.
I don't know. It's a pretty good one.
Hmm.
And I find that again that visual feedback, and most of the voice clients I've ever had were voice tied into more digestive issues with things like GERD and how it impacted their vocal cords over a long period of time, or even a short period of time for people with severe GERD. And so we use that as more like a feedback, visual feedback kind of tool, at least for me, because I wasn't really treating just the voice. It was more about the swallowing and the impact
Mhm.
on the impact that the GERD was having on their voice.
Yeah. And it's an interesting app. I will, just for people who aren't familiar with it, where it tracks pitch and some other parameters, but I'm always a little, I do have some sort of disclaimers when I present something like that to patients, that it does have these very stark sort of guidelines of like a male voice will be between this and this, and a female voice will between this and this. And there's this little sliver, like you mentioned, of the androgynous zone, and it's a little too cut and dry. And so I always counsel patients that, I know plenty of folks that don't fit within this guideline, and they're still, being perceived the way they want to be perceived. So,
Oh yeah, and like I said earlier, I'm in Virginia, so we're in the pollinating right now, the pollinating season, and so this morning I sounded completely different than what I do right now because allergies, and I was in the garden all day yesterday, so I got up this morning and I sound like a dragon. So
oh gosh.
Darth Vader's twin first thing in the morning.
Yes,
So,
I've been there.
so let's talk about the typical flow for gender-affirming voice care and what that looks like for patients because this is not a population I've ever worked with, and so I'm really fascinated and very interested to learn what the flow looks like for
Mhm.
that patient.
Yeah, this looks different depending on what center you work at. I'm really fortunate that I was brought in to kind of lead this charge and to expand what we had going on here at USC. So this is what I created, which is why I like it the best. And what we found is, before, people were coming in wanting gender affirming voice training or therapy with a speech pathologist, and they would have to wait such a long time to see the doctor in clinic, and then also see the speech pathologist in our interprofessional clinic, and then get referred for voice therapy. And so the way that we have changed it to sort of expedite care and increase access is that if someone just wants voice training or voice therapy, they don't need to come in person. Or if they come in person, they can just meet with a speech pathologist if they don't have other medical issues, or we're not picking up on any red flag symptoms that would necessitate laryngoscopy or looking at the vocal folds. So we're pretty good at hearing voices and sort of deducing if we think there's some other underlying pathology. So if they're really just coming for gender affirming voice training, then they see one of us. We have 5 voice specialized speech pathologists on our team. We're really lucky, or 4 plus a fellow. And they meet with us. Usually the first session is intake, getting to know the person, how they identify, maybe what their voice sounds like now, what they like about their voice and maybe want to keep, and then maybe what they want their voice to sound like. And knowing that we really spend a lot of that good time to understand specifically what they want, recognizing that there's no right way to have a voice. Just as many humans as there are on Earth, there are that many voices. And so finding out specifically what elements they might want to work on. I introduced this concept of the voice puzzle, or, with different puzzle pieces like pitch or resonance or melody. Sometimes we'll talk about this more probably when we're talking about training, but I'll call it the voice soup sometimes, or the voice outfit with different outfit pieces, or the voice soup with different ingredients, and kind of dive into what specifically they want to change. Every now and then people will come with really specific ideas or a voice model, like I want to sound like uh, Aubrey Plaza, or I want to sound like Matthew Gray Gubler from Criminal Minds, or, specific things. More often than not, they won't, and that's okay. We'll kind of, take this really exploratory approach. So, kind of diving into different aspects of voice. And then we'll just dive in. I think I take a very exploratory approach, like I said, very non-prescriptive. I think that my goal is kind of the almost like the passenger seat driver. Like, I might offer you some pointers of where you might want to try to go, and you can try on this strategy and tell me if you like it or not. And then we'll maybe combine it with a different puzzle piece or a different soup element or whatever metaphor I'm using that day, depending on how hungry I am. And
Acute care.
yeah, exactly.
Or even outpatient, because we
Yes.
don't have that kind of time.
Oh my gosh. Oh, so yeah, I think it's all from there we kind of get into the trying out strategy approaches, and that's the one pathway just for folks who are coming just for one-on-one, training. We also then have another pathway if someone is seeking gender affirming voice surgery, so like pitch elevation surgery, or we'll talk about a procedure for lowering pitch for transmasculine people, folks that are assigned female at birth but identify with masculinity, just to define that term, transmasculine. Then if they're going to have something procedural or surgical done, then we'll see them in clinic with the MD. And even now, another pathway that we have is this year I established a group therapy at our clinic. And so right now that's for people who have been working on their voice a little bit, but want more of a practice environment with other trans people that are also working on their voice. So sometimes they'll end up going into the group therapy. So lots of options.
Yeah, no, it's funny that you said what you said about people wanting their voice to sound like a specific person, because that was immediately what popped into my mind was just, do people come in and say, I want to sound like this celebrity or this famous person in Broadway or whatever? Because I'm sitting here thinking about uh like I said, my voice this morning, I sounded like a dragon, and
Yeah.
now I sound more like me. But what would I ultimately want to sound like? I have no idea. I just
Yeah.
know that mine was more when I went to graduate school, mine was more we had to pass a speech and hearing screening. It's basically like you have to be able to hear, close your eyes and hope you can hear the tones because they put them so, they're so quiet. It's insane. But
Yeah.
I got flagged for my accent specifically, and they wanted me to do accent modification. And now I'm like, that's hilarious because
Wow.
I don't think it would have worked, but I also don't think it diminishes my ability to be a speech language pathologist,
Mm-mm.
just because I sound a little differently. So
No.
that kind of took me down that pathway. But oh my gosh, like,
Yeah. And
do
I think
people want to sound like singers? Do they want to sound like
yeah,
celebrities? Is that even a thing?
sometimes, yeah, those two I've had Plaza and Matthew Gray Gubler. I've had a
That's
couple times, or Renee Zellweger, sort of in like the kind of like sort of, I don't know, more sultry feminine voice. Sometimes I'll
that's
have
not someone I would have picked.
I know, yeah, just sort of just the most random things will come up, or I'll ask, do you have a family member that maybe you want to sound like? Because like with the
Okay.
accents, I've had folks, with all sorts of accents from around the States or around the globe, and they want to maintain that accent, but maybe sounding more so like, a radio host from their home country or something like that. So asking that question
Wow.
brings up a lot of cool things to explore.
Yeah, that does sound cool. Now I might have to rethink what no, I'm kidding. It's, but
No.
it's very interesting because it's I did a accent modification podcast with Bob McKinney out of California uh about a year ago, and well, it hasn't been quite that long. It was supposed to be about a year ago, but it was funny because I thought I knew what accent modification was, and again,
Mhm.
it was a learning curve for me and an experience because really what I thought accent modification was is not what it actually is. And I think that's the reason I was so excited to do this with you, just because there's a lot of unknowns for those of us who do not work specifically with voice, but also with gender affirming voice, because I thought one of the very first things you said about people wanting to sound either that were cisgender who want to sound either more feminine or more masculine was very interesting, because I don't think that's what the general public thinks
Mhm.
this therapy is about at all.
Yeah, yeah. It's so broad. I think like the term gender affirming can be so, you know, used in so many contexts. But I think it's just about building something that feels authentic, to whoever we're working with. I think in like traditional voice therapy, we are trying to get someone back to their old voice, if they've lost it from whatever they might have. And I think a cool part of this work is with when specifically working on gender affirming voice with a trans patient or a non-binary patient, whoever, we're working on finding that authentic voice that's new and building that together.
How long, well, and I'm sure it's patient specific, but
Mhm.
how long does that entail? And that's, this is more of like probably a three-part question, but just in general, how long would that look like as far as a course of therapy?
Yeah, and you're so right. It is so patient dependent. I think it can be anywhere from a couple of months to a year for some people. And I might not be seeing them, every 2 weeks for a whole year, but sometimes I'll see someone, every 2 weeks for a few months and then take a couple months off, live with it, tweak it, come back. So I might see, someone for a lot longer than a few months. It's just totally dependent.
And I think that's probably a really good jump off point for talking about the gender affirming voice surgeries, because that's another area where I feel like, we think about voice surgery, it's typically a vocal fold injection for true vocal fold paralysis, or, someone has granulomas or some kind of pathology that needs to be removed. We learned a lot about that with Steven Tyler of Aerosmith being in the media and doing some pretty cool YouTube videos to show the surgeries and what that looked like. But I think the general public, again, isn't super familiar with what these surgeries are and what they entail.
Yeah. That's so true. Yeah, there's a lot of the pop stars in the media are more open about those surgeries, which I think is really cool. But these types of surgeries are more rare. I think just thinking about how many trans people less than 1% of the US population is trans, and way less than that actually get these surgeries. So, it is really rare. The surgeries that exist kind of do one of two things. The most common surgeries aim to elevate pitch because folks that are trans feminine, so assigned male at birth but identify with femininity, some trans feminine folks really struggle with raising their pitch. And if they're transitioning with hormones, those hormones like estrogen aren't going to do anything to the larynx. Whereas trans masculine people who transition with testosterone, of whatever form, testosterone does lower pitch. So they're a little bit luckier in that realm. So most of the surgeries aim to elevate pitch. There are a number of them. The most commonly performed is called the Wendler glottoplasty. And then there are some other ones. One is called the FemLAR, feminization laryngoplasty. And that one I know the least about. I have not met anyone who underwent that, and the surgeons I work with don't do that one. And then there's another called the laser assisted voice adjustment, or LAVA, which I think is just very cool because it's lava. And that I'll talk about really quick is done at our center a good bit, and maybe not all centers that do voice surgeries. That involves lasering while the patient is asleep, the lateral edges of the vocal folds. So not the vibratory edge, if you can
Mhm.
imagine, sort of closer out or farther out, sorry. Lasering sort of a line or like a trough in both vocal folds. And the aim of that is to increase tension. And if we think about kind of like you're increasing tension on a guitar string, it gets a little bit higher in pitch. And so that's sort of the idea there, to elevate pitch. And that one doesn't elevate pitch as much as the Wendler glottoplasty, which elevates pitch the most, but also has the most sort of give and take cost benefit analysis. That one is most commonly done. That involves, again, lasering or using cold steel to take off the interior, about half, third to a half of the epithelium or outer layer of the vocal folds. So if you can imagine the vocal folds as a V, for those of you that are actually watching this live, you get my good hands hand model. Um, so de-epithelializing or lasering or cutting away with a cold steel instrument, and then the physician or surgeon will suture together that spot and form on purpose, form an anterior web. So you might see in your clinic an inpatient or outpatient patients that have an anterior web as an injury, an accident.
Yeah.
And so this is purposefully doing that and webbing together the vocal folds to create, again,
Wow.
increased in tension, decrease in mass and length and things like that. So that increases the pitch too. But that one has a lot of potential downsides, like for sure a decrease in power. So if someone comes to me and their first thing is, I don't want to lose the ability to like fill up a room with my big sound, or get the attention of all my loved ones, or have this huge loud boisterous laugh, then that's part of our counseling, that one definitely affects loudness, but it definitely increases pitch.
Yeah,
Mhm.
well, and that makes sense if like you go back to, oh my gosh, that like gives me palpitations, but voice and the voice course in grad school and like how vocal folds when they stretch does
Mhm.
increase pitch as far as like lengthening and
Yeah.
it's interesting because yeah, you're right. The only time I've ever seen webs was not a good thing.
Right.
It was a bad thing. We had to refer to ENT like you should go now because your swallowing looks terrible.
Uh-huh.
And that kind of thing. Or, yeah, that's really mine was always more impactful for swallowing when I saw that either on a fees or depending on if we could do different views on a modified barium, you might see something that indicated a hint of that might be what's going on.
Yeah,
So
something's
that's,
going on.
yeah, that's really interesting because again, I had no idea. So would you say that the lava and the other one are kind of 50-50 at your clinic or
That's a really good question. I think maybe 70-30, honestly. More so the Wendler glottoplasty is done. I think, the elevation and pitch is definitely more, and it's the more well-known surgery too. So I think people come into clinic having done their research and they want, the one that they've done research on. But some people maybe want a stepping stone. So some people will have the lava and then the Wendler, just get a little taste of, I want a little bit of an elevation and maybe that's sufficient. And then some people will have that and say, okay, I do appreciate this elevation and pitch, but I want a little bit more. And so then they'll have that. Or vice versa. Some people will have the Wendler and be like, okay, I'm not quite there. I want just a little bit more. And we have one or two patients that have then had the lava afterwards. So it's
oh
interesting.
wow.
Yeah.
Wow, okay. What is the recovery time for those?
Great question. That's a huge thing that goes into our job as the SLPs preoperatively, most specifically, is getting them ready for this because the healing time is intense. Voice rest, complete silence for at least a week. Some centers out there, some surgeons will tell their patients 2 weeks. And I've seen in the literature even more than that, but I don't know any physicians personally who say any longer than that, especially for the Wendler glottoplasty, where you have these sutures that are holding things in place, hoping for this scar band, this web to form. You don't want to talk and rip those sutures out. I know.
Or cough, or if
Yeah.
God forbid you cough.
I know. Yes. So we'll teach some cough suppression therapy techniques. We'll talk about voice rest and alternative communication techniques, while they're being silent. Yeah, because when I was in kind of a tangent, but when I was in grad school, my first ever voice patient that I had at the Boston University Voice Clinic was a woman who had had a Wendler glottoplasty, and she yelled at someone. She had to yell, and her sutures tore, and it was pretty tragic. And it took a year to kind of heal from that, and then had to, then thankfully was able to get a voice that was better suited for her and met her needs, but it was pretty tragic. So I'm always holding her in my heart and in my head when I'm doing these counseling sessions or education, pre-op therapy. But then the healing is intense. So the voice usually sounds pretty terrible, for lack of a better word, right
Oh,
after the voice rest, and doesn't really start to sound the way that we think it'll end up sounding for a few months. So it is an investment in time and dedication for sure. Because yeah, it takes a lot. It's a huge injury, and therefore it takes quite a long time to heal from.
Yeah, so I was thinking like that's got to be some pretty edematous tissue,
Yep.
and that, weighs everything down and
Mhm.
makes, oh gosh, I have a lot of thoughts. But let you let me get back to what we're talking about, because I'm thinking about edematous tissue and like how that impacts your swallowing and
Oh,
your chronic throat clearers and people with GERD. But we could go that route if we get time at the end. Bring me back, because you got my wheels turning up here. So yeah, can you talk about what our role is as SLPs for those patients prior to surgery? Like what does the pre-counseling look like before people do gender affirming voice surgery?
yeah. A little bit of what I was saying before, kind of like teaching other ways to communicate. So talking about, low tech, medium tech options, for communicating, whether that's pen and paper, voice to speech app or text to speech apps. My favorite app, it's called Big. It's free and it just makes the text on your phone super big so you can type out I want a vanilla latte, please. And it makes it super large so the person across the room can read it. Or anything, communicative like that. Talking about counseling for expectations is a huge thing that we do, and counseling for those risks. So counseling, to make them aware of some things that might not be amazing, at least right away. Your voice is not going to sound good the first time you speak after this surgery. Don't be alarmed. Don't be upset. Don't go into the, oh my God, what did I just do sort of mode. Counseling for expectations of what this will and will not do. I called these really specifically what they are. They are pitch elevation surgeries. I think people sometimes call them voice feminization surgeries, but there's so much more to a feminine voice, quote unquote feminine voice, stereotypical feminine voice, I should say, than just a higher pitch. You can have a high pitch, but if your resonance is really far back, or, XYZ is not also being changed, then you might not notice a big change in your voice, even though the pitch is higher. So education of those elements. We might even start teaching those elements preoperatively, and then teaching some easy exercises. So I think my whole team and most of the people who, work with these patients are huge lovers of a SOVT, a semi-occluded vocal tract exercise, which if you know nothing about voice, you probably know straw and water bubbles.
Yep.
And it's my favorite. It's my favorite exercise. It's so good. It's a classic and it's well known for a reason. So I'll teach them some easy SOVT, probably straw and water bubbles, to start using after the voice rest period, just to get voice happening again in an instrument that's been so changed. I'll often use an analogy, you went to sleep with, one, like, I don't know, a trombone in your throat and you woke up with a trumpet in your throat. Like you have to kind of relearn. So teach either lip trills or humming or straw phonation, something like that, that they can start doing after they're sort of given the all clear to start using their voice again. And then afterwards, it's, once they're given the all clear to start back with voice therapy, we usually see them at about the 2 week mark. Excuse me. Maybe we'll do some easy voicing tasks just to increase, ease of voicing, working on airflow, working on where the resonance is coming from, different things like that, as we're just waiting for healing to happen and optimizing those other elements of voice or pieces of their voice puzzle.
Yeah, it's interesting because one of the undergraduate course I teach is clinical observations is a big part of that course. And one of the sessions I have the students watch is specifically about gender affirming voice therapy. And even though I've watched it several times, there's a lot of things that are, because those recordings are older, they're not necessarily up to speed on the last 5 years of data and research and evidence-based practice. But semi-included vocal fold or vocal tract exercises are in it. And there's a really focused effort on bringing that voice forward versus having it in the back, which
Mhm.
takes me to like the basics of voice with like Joe Stemple and
Yeah.
uh, I'm trying to think of who the other person who I've been to a course on years ago just to learn more about placement really because it
Mhm.
helps with for me working with more neuro patients like people who've had strokes and TBI and things like that. It helps some with dysarthria too, being able
Mhm.
to change the placement of the voice, and
Mhm.
where or like the articulatory structure where you're placing the stress on your articulators. So I think it for me it's always kind of going back to the very beginning, talking about the niches, but then we have to look at how all these things are interconnected and how our brain works, but also how we, as speech language pathologists, have these foundational basics. But I think we sort of forget we're still using some of these techniques in other disorders, and that's why we learn them in
Mhm.
graduate school because sometimes we're like, what the heck are we doing? I don't need to
Yeah.
know this. I'm working with TBI patients, right? But then
Right.
you might have a TBI patient with a voice disorder based on the fact that they had a prolonged intubation or tracheostomy or they self-extubated and now they have a vocal fold paralysis issue. So I think for me, thinking about it in those terms of relating all this makes a lot more sense than trying to just be singular in how we think about voice and how we think about TBI is this and
Oh,
gender
yeah.
affirming is this. And I think it makes a lot more sense to think about it that way.
Oh, totally. Yeah, I think you're so right. I think that people sometimes hear voice and they're like, "Oh, I could never do that." And I'm like, "Well, it's skill. If you know the anatomy and you know how the larynx works, then you know how to change the function and walk someone through that." And I think gender affirming voice training is, obviously really, really specialized, but we can operate and do gender affirming care anytime we see someone, anytime we use the right pronoun or call someone by the right name, we're doing gender affirming care. We're just affirming who they are.
Yeah. And
Mm.
I think that's a good point with, gender affirming voice therapy sessions and what that looks like. Because again, I came into this tonight thinking I have no idea what we're talking about, and yet you're saying all these smart people things, and I have questions that are like popping off in my head about all of that. So, can you walk us through it, what a gender affirming voice therapy session, either without surgery or with surgery, what those look
Mhm.
like? And you kind of
Totally.
talked about with surgery already, because like the pre-counseling and
Mhm.
like preparing people, but what does it look like later on?
Yeah, really great. Or, for people who don't have, I think who don't have surgery, because I think the majority of people that at least that we see here don't end up getting any type of surgery or procedure or anything like that. They just do therapy, which I think is the across the board, sort of globally, the norm. And it's so funny you're talking about, the Stemple and these other, big, you know, founders of what we think of classic voice therapy approaches. And I always say I use the exact same approaches for someone with a voice disorder that I do in gender affirming voice care. The Stemple, vocal function exercises. I don't use that very often in gender affirming voice care, but it's been researched for use with this population and can be beneficial for training either lower parts or higher parts of someone's vocal range. I almost always do a semi-occluded vocal tract exercise just as a warm up and as a way just to maybe get someone in touch with different parts of their vocal range that maybe they're not used to phonating in in a way that feels less pressure than okay, talk higher or talk lower. I'll use resonant voice therapy with every person I meet because so much of gender affirming voice training is resonance as well as pitch. Resonance being, how forward or bright or dark or back you're kind of speaking. I can talk really, really forward and I can go almost to like the Valley Girl, which I can say now, as someone that lives in Los Angeles. Or I can go, really far back and like I'm not even really changing my pitch, but I'm placing my voice really far back in my throat. And so that resonance and awareness really comes into play. I'll use elements of CTT, conversation training therapy, another gold standard for working with folks with voice disorders and also being pulled into this realm. So I think, yeah, it is so similar to other types of voice therapy that we do. I'll usually start, maybe focusing, well, actually, let me backtrack. Often I will focus on an element at a time. However, a lot of people can get overwhelmed by that. Okay, I have to think about my pitch and I have to think about my resonance and I have to think about my articulation and my melody and my intonation, the prosody things, and I have to think about breathiness and vocal weight, and all these elements can get overwhelming. So sometimes I will pause and take more of a gestalt approach and just say, what would it sound like if your voice was neon green? What would it sound like if your voice was baby pink? Either taking a color approach, which I take from my years as a choir member and choir teacher, or what would it sound like to have a stern voice or a preppy voice or a voice that tastes like bubble gum, like very sort of abstract as well. And that really works for some people. Other people will look at me like, what the heck do you mean voices don't have tastes?
They might.
Right? They might, to some people. And so it's so different. I think every single session is so different, but it's working on, things in different ways. Sometimes I'll take a conversational approach and we'll just add in different ingredients to their voice soup as we keep chit-chatting. And to some people, that's too overwhelming. So we'll kind of go the classic resonant voice therapy hierarchy, sort of starting, okay, let's start at the single sound. Now let's do a CV, consonant vowel, maybe repeat that a few times, like me, moo, moo, moo. Then go to the word, phrase, sentence, paragraph level, keeping your voice consistent. So there are so many ways to do this work that I think it can be overwhelming, but I think it's also exciting and an adventure every time.
Yeah, and well, it's interesting because you're saying the me,
Mhm.
and we those of us who treat Parkinson's patients, if you do speak out, we do that as our vocal warm up.
Yeah, that's right. Oh, I loved my speak out days.
Yeah. No, oh, they don't pay me, and I have to say that, but I love that program
Right.
so much. I really do. And
Mhm.
I have someone who is a mentor of mine who got the Parkinson's diagnosis a couple of years ago, and he actually
Mhm.
went and took the course because he met someone in his boxing class for Parkinson's folks who didn't have access to speech therapy, and
Oh,
he still had a license. So he went and took the course so that he could not only help his voice stay strong, but help his
oh,
buddy in boxing class, which was really cool because he does bill for it. But it was a
oh,
really cool thing because he said the same thing. He's like, this is like taking me back to way
yeah,
back when we would warm up voices, and he's older than me, so he has like a his background of voice. It's still some of the same basic techniques as my whole point.
yeah,
Is that things like barriers and boundaries where we again don't think about that and how we're able to use these things, because most everybody, when you say voice, they're like, oh, or oh no, I
yeah.
don't.
Oh, totally. I mean, there's so many things that I think great therapists are great thieves. I think we steal and we piece together, different ideas from different people that we meet, like I have spiels, when I'm explaining a concept to someone that I've stolen from, whoever 5 years ago. I was really lucky in grad school to do a thesis at Boston University in the STEP lab that which was taking ideas from Nelson Roy's work looking at mutational falsetto or puberphonia, where they were doing laryngeal reposturing and massage. And we applied that to the speech pathologist at the time that was working, since I was a grad student, applied that to transmasculine people, and it helped, lengthen the vocal tract, deepen pitch. And so now that's something that I'll use as well with people is doing massage in treatment as well. So anything you can think of. I think we think of this word as like eclectic. Like I think gender affirming voice therapy is very very much eclectic in nature.
Yeah. And you've talked a lot about some of the techniques. So when you say strategies, are strategies and techniques the same thing, or is there a strategy teaching moment maybe that you have with your clients that are it's more like client centered, client specific, based on not only their goals but maybe also the surgery? Because I keep in my mind I keep going back to the surgeries and I have a lot of
Yeah.
questions.
Yeah. Gosh, I mean, I think it's so varied. Some people, I will take more of that systematic approach, like not prescriptive, but a little bit more systematic. Again, being a great thief and collecting my little things in my voice therapy toolbox over the years. There's a routine from a voice teacher, Liz Jackson Hearns, who owns like a voice teaching studio, who wrote a book called One Weird Trick. And there's a protocol in there that sometimes I'll pull from, and I'll use that protocol for someone who maybe needs a little bit more structure, because sometimes I can be a little bit too free. I was gonna say free willy. That's not what I can be a little bit too free willy with my approaches, a little bit too exploratory and free flowing. So some people need a little bit more structure. So I think it is meeting them where they are in so many ways. And that goes with all of our care, I think, no matter what, if we're seeing someone post-stroke or someone, with whatever we're seeing, we're meeting them where they are and treating them the way that, like, providing treatment in the way that they want to learn.
Yeah, and I'm thinking about like upper airway
Mm-hmm.
things. Oh, so I say things, and I mean, upper airway pre-existing conditions. Like, are
Mm-hmm.
there parameters? And I know, you're not obviously you're not the physician who's performing the surgeries, but in the pre-counseling role, are there things that are pre-existing conditions as far as upper airway, like COPD, or maybe history of like a weird tonsillectomy gone wrong, or anything like that where it would be a barrier to, or even a red flag for maybe them not being a candidate for surgery?
Yeah, really, really good question. As far as I know, in terms of like pulmonary stuff, have not come across that. I think if they are like a really ballistic cougher, we may consider doing some cough suppression therapy, a course of that before surgery. It's funny I mentioned Ranke's edema and we chatted about that earlier. We had a patient recently with Ranke's edema, and that is something that needs to sort of be taken care of, and smoking cessation prior to surgery. Obviously, we don't want someone smoking, over a fresh, suture, fresh injury, and, Ranke's being such the way that it is, that it makes the vocal folds so it can kind of impact surgery. So there are some things, or maybe if they had, vocal fold polyps or something like that, if they had underlying things, those would probably be addressed first. I'm just thinking about any possibility now. You're getting my mind reeling. What would we do with someone who has unilateral vocal fold paralysis or something like that? I don't know, but I think a lot of those things I have not seen, but would suspect we would do kind of treatment for those things first.
Yeah, and that makes sense because again, we see that with my world of traumatic brain injury and more neuro based diagnoses where you might have someone who had a stroke and now they've got some neurogenic disorder, dysarthria, something like that, Parkinson's with dysarthria, which that's one of my sticklers because I keep seeing SLPs with experience saying that hypokinetic dysarthria is a voice disorder, and I'm like, but it's not. It has a component of voice that, but
Yes.
stop calling it a voice disorder in your documentation because it is a dysarthria
Yes.
with a component that impacts the voice
Yes.
weakness. So, and the
Mhm.
difficulty with motor speech. But yeah, I don't know. What about swallowing? Do you ever see impacts from the surgery? Because you're talking about, vocal rest, and obviously cough would be an issue, throat clearing would be an issue with these sutures. Do you ever see anybody with issues with swallowing post surgery?
I have not actually,
Oh,
which is
cool.
really
Okay.
good. It's not impacting vocal fold movement. So like protection of the airway isn't impacted, which is good. I don't know, I'm just thinking of any theoretical possibility. Foresee, if maybe someone doesn't heal properly and maybe they have, maybe like a keyhole aperture, maybe the web doesn't go all the way down to the prior anterior commissure. Maybe that could be a problem, but I haven't seen anything like that, luckily, which is really good. So that's typically not part of our counseling of things to be aware of.
Oh, that's good.
Yeah, it's
Yeah, 'cause
good.
it's good because that's again, thinking about, and I'm still hung up on the whole cough thing, because again, in Virginia right now we have the pollinating, which means everyone is sounding horrible for the most part. You go outside for 5 minutes and you sound like a dragon or Darth Vader or a combo.
Yeah.
Um, and yet, I don't know, I'm thinking about just like everyday life and people who do have like chronic sinusitis, or maybe they've had some issues with laryngitis from overuse or misuse of their voice, and how that would impact not only their ability to have surgery, but then their ability to recover, because we know that all those things sort of have this, ongoing impact on vocal
Mhm.
fold movement. Again, the edematous tissue that may be present prior to. So that brings me to another good question, because I think a lot of people maybe don't have background knowledge or know who would be on the team for this type of surgery.
Mm. Yeah, ideally, in the ideal world, you have a practice such as mine, which is I'm very privileged to work in a true interprofessional practice where we are, in the clinic room with a physician. So I know that I'm very privileged from working with my dream team. But ideally, a surgeon who is specialized in the larynx, so a laryngologist would ideally be doing this surgery. And then the speech pathologist, and hopefully, you have good relationships with your laryngologist, whether at your practice or in your community. There are some laryngologists that don't have speech pathologists in their clinic, for whatever reason, or maybe that's not how the hospital's set up to have in a professional practice, but having that connection so that, it impacts the patients for sure. There are some physicians that don't refer to speech pathology perioperatively, and we know that patient outcomes are better when they have voice therapy and a surgery versus just the surgery alone. There's a paper, it's a few years old, so I don't remember all of the authors, but I think Sarah K. Brown and Dr. Mark Corey were on a paper a few years ago where they did some retrospective looking at patients who just had a one-layer glottoplasty versus patients who had a one-layer glottoplasty and voice therapy, and outcomes were better. I think, again, it's been a few years in terms of patient-reported outcome measures, and also just like pitch elevation too, because they worked on pitch with the therapist and also with the surgery. So, hopefully those two players hand in hand along with the patient. I work in a great place where we have, PT, OT, SLP, we all communicate really well for different types of surgeries, but for these, really just the SLP and the laryngologist.
Okay. Well, and
Mhm.
that, I think the probably one of the last questions I'll ask,
Uh,
'cause I've thrown in a lot of extra stuff.
I love it.
I'm always thinking about like trauma-informed care and mental health awareness, how much of that comes into play prior to the surgery and even after, because I think there's a lot of component of needing to have this mental health counseling support. Is that someone who's a member of the team?
Yeah, great question. It is often a really important step. We know that voice incongruence impacts mental health quite a bit. I recently did a qualitative study that's going to be published hopefully soon in AJSLP. It was accepted.
Oh, good for you.
And
Yay.
thank you. And presented on it at ASHA, where we interviewed 15 trans feminine people before starting voice therapy. And so many of them talked about the mental health effects of their voice and their hope for positive mental health gains as a result of voice therapy. So even if they aren't seeing a mental health counselor, which I often will just bring up and say, hey, I love going to therapy. I love my therapist. Do you have someone that you talk to about things, when life gets hard? Even if they don't, I think that that component of mental health comes into play in the voice therapy room, whether or not they're having surgery. I think it is huge. Yeah, it is. And I love that you mentioned trauma-informed care because obviously, you know, any minority population is going to have increased trauma that they've experienced. And I think that, if we're, paying attention right now, a lot of these groups are being, subjugated to a lot, especially the trans population. And so I think just showing up and being kind goes a long way to impact people's lives.
Yeah, and providing that safe space where,
Mm.
and I say this a lot, we have this different relationship a lot of times with our patients and clients because we tend to be one-on-one or in a more secure treatment room versus being in a gym with a bunch of other people or being in a space with a lot of other
Yeah.
people, with the exception of like what you mentioned with doing the group therapy. But for us, our patients from acute care down to outpatient, down to specialized care, they tend to say things or share things with us because we do provide a safe space, but also we are hopefully active listeners, and it's a learned skill. It's not something we just automatically do. We're speech language pathologists. We like to talk. Kind of why we do this. Well, besides the whole helping people part, but part of our
Yeah.
job is to talk
Mhm.
and to share knowledge. And I think that, for a lot of people, that active listening space is so important because often their voice isn't being heard.
Mm.
Uh, and then it is a place where they do tend to share things like their mental health concerns, and then we can hopefully help refer them to the appropriate professional to get support and care, and even care for their caregivers too, because that's a whole other population and the conversation we could have a whole other hour about. At least for me, I could talk
Oh,
about
for
care.
sure. Yeah, I'll come back.
Come on, you're welcome anytime.
Oh, but
Well,
yeah.
Felicia, thank you so much for joining us. This has been just super informative, not only for me and hopefully for our listeners, but just allowing me to ask those extra bonus questions that were really informative, I think, for people, and kind of opens the door to thinking about how we can provide better services and more inclusive services for our clients, because this is an area of need for our clients.
Mhm.
There aren't a lot of clinicians who are willing to step into that space, and hearing your experience and your expertise is, I think, very helpful and encouraging for people who are kind of on the, thinking about, do I want to do this? And our
Yeah.
our upcoming students who are about to graduate in a couple of weeks, so maybe some of them will want to go into this realm too. So again, I really thank you for being with us. And do you have any last remarks for us before we head out for the evening?
Yeah, well, I think if you are at all interested, like you said, there is a huge need, and there's just a need for providers that are kind and willing to learn. And I think there are great resources online. I'm happy to be a resource to anyone who wants to learn about this topic. As you can tell, I can talk about it endlessly. And so I think, do the good work, if there are terms you're unfamiliar with, educate yourself and learn about the voice. And if you know about the voice, you can do gender affirming voice. So start there because there's even more trainings there. But I don't know, just come to it with openness and love and kindness, and it'll be appreciated. And thank you for having me.
Of course. Thank you. Again, thank you, Felicia, and we look forward to seeing you again.
Thank you so much for having me.